Okay, all right, we're back. All right, so video number 2 of Airway. We're going to talk about how to cric people. So we'll talk just like the mechanics of it and some pro tips. With full disclosure that I prepared for this moment for 8 years, but I've never actually criced somebody. I've been in the room when about 25 people have been criced, but I've never performed a cric myself, either because, I don't know, I suppose I'm just lucky, or I always get the airway. I don't know. I like to think about the second one, but I think it's just I've been lucky. Most people who have done this job long enough have criced somebody. The decision that you need to cric somebody, you should probably make it early, make it before they code, give the patient a chance, okay? Here's my cric model. This is a male cric model that I got from Rich Levitan, who's like an airway wizard. Basically, when you decide that you need to cric the patient, you just have to make that decision and go. If the casualty is conscious, I would use lidocaine if you have it with you. If not, you could use ketamine. If the patient is in a mental state where they're not responsive, then you don't really need to use anything. You can just make that cut and go. So if you see here on our picture, all right, so this is our thyroid, I'll move this closer, our thyroid cartilage. Okay, this is our trachea down here. This is our cricoid cartilage. When you're feeling this on a person, this, on a male patient, this like large prominence in the throat is usually that thyroid cartilage. And then you go down, there's a small space there, and that second smaller prominence is this cricoid cartilage here. That is where your cut is going to go, and you can see that on this image on the left. You're gonna stand on the side of the casualty that is your handedness, your dominant hand. So if you are right-handed, because you're normal and you're not a weird person like a lefty, you're going to stand on the casualty's right side. Okay, see if I can bring my camera down. And what you're going to do, I'm standing on my casualty's right side. I feel up and I feel this thyroid cartilage. I feel the dip down and I feel this cricoid cartilage, and I say, okay, this is the spot. This is where I need to go. If the casualty is obese or has a thick neck, what you could do is you can put your finger in the suprasternal notch right here, place 4 fingers here, your pinky here, and then where your index finger is, that's relatively close. It's I guess I have like a giraffe neck. Mine's a little bit too short, but right there is where I'd go for me. So this, like, I don't know, hand of God, I'm gonna cric your neck move with the 4 fingers on the thyroid, or the, sorry, suprasternal notch could be a way to let you know if the person has a really fat neck. You're going to stand on their sidedness. So this is my casualty. I'm on their right side. Okay. What I'm going to do is I'm going to place my, sorry, I was just like, bad camera work. I'm going to place my elbow on their chest. I'm going to take my claw hand and I'm going to stabilize this larynx, because if you look at someone's neck, dude, like this moves. That like moves pretty aggressively. Okay, and so what you don't want that thing doing is slipping around like a slippery fish while you're trying to cut, and there's shooting happening, and everybody's freaking out, and the person's dying. You may like know this person. So, claw hand, stabilize the larynx. You have your right elbow, your dominant hand and forearm on their chest. Okay, remember they could be breathing, could be not breathing, but they could be breathing, so you have to stabilize yourself. You're going to take, this is your weapon. This is your scalpel. It looks like a pen, but it's a scalpel. Stabilize the area. Feel with your non-dominant finger. You feel your thyroid cartilage. You feel your cricoid cartilage. You feel that small dip in there. You know where you're good to go. And you're going to make your 2 to 3 centimeter incision horizontally. Okay, horizontal. You're going to feel down. Confirm you are in the right spot. You feel like you're in the cricoid. The space between the thyroid cartilage and the cricoid cartilage, and you feel like you're in the cricothyroid ligament. Then you are going to make a horizontal. First you're going to cut vertical, then you're going to cut horizontal. Don't worry, you can't damage anything back here if you go too deep. Obviously you don't want to go too deep on purpose, but this is actually relatively safe. There is cartilage behind this area, so don't worry about stabbing into their spinal cord thinking you're going to go too deep. You're not going to go too deep. Vertical, then horizontal. You're going to take your bougie. This looks like a straw, but it's actually a bougie. And you're going to put, you have your finger in here. Okay, sick, I'm in the space. They're not going to die. I'm going to save them. Put your bougie in there like this. Okay, and now you have your bougie in there. You might even feel the cricothyroid rings. And then this is your cric kit, or if you take a 6.0 ET tube, you're going to put that over, feed it over, blow it up, bougie out, end tidal CO2 on, bag the patient, excuse me, bag the patient, confirm you have color change on your end tidal color change colorimetric thingy, or you have an EMA, which is an end tidal CO2 capnography. It's like a finger pulse ox, but it's end tidal for your ET tube. And that's how you correct somebody. Tape this up, secure this up, suture it down, use the stupid strap that it comes with. Whatever you gotta do to secure it down. But that's how you correct somebody. It's gonna bleed. It's a tactile procedure. Feel it with your fingers. It's going to bleed a lot. If it's not bleeding a lot, they're probably way dead and you waited way too long to do it. So it's gonna bleed. Just know that. That's fine. That's normal. Don't get too lateral, okay? Stay midline. There are important arteries like we discussed earlier in that other picture, so don't go too crazy. You'll cut into the like thyroid gland and like you don't want to mess with that, okay? That's how I correct somebody. Easy peasy. You need to mentally put yourself in a headspace that you're the person who could correct somebody. If you go on deployment or you approach a car wreck or you go to work one day and you think, dude, I don't need to worry about that. Like that's never going to happen to me. If that happens to you, you're in deep shit because you are not ready. When our expectations and our reality are not congruent, that's where huge problems arise. Our expectations and our reality need to be the same. So we need to go into a critical situation, such as a deployment, such as a casualty, a mass cal incident or whatever, or even just a day at work in the ER, like this cardiac arrest last night at work. And like you need to go into those things knowing something bad could happen, preparing for that bad thing, and then if something bad does happen, dude, all good. I've already crossed this bridge. Now I just need to perform, and then I'll deal with the residue of what happened, the deaths, the visually stimulating images that I saw. I'll deal with that on the back end, but in the moment I was able to perform because I prepared for it before. It will still affect you. It will still be problematic. It's not normal to correct somebody at work. It's not normal to watch somebody die. It's not normal to see somebody get shot in the neck. Those are all not normal things. You'll deal with that on the back end. But in the moment, that person doesn't need you to feel bad for them. They just need you to perform. And you're not going to be able to perform unless you do this, unless you cross this mental bridge before you need to do the cric. Okay? It's kind of a diatribe, but I feel really strongly about that. All right. Visualize yourself doing it. Run the steps through your mind. Practice the steps. You're going to suck at everything that you have not practiced. There is no such thing as natural talent. Natural talent is a myth. Okay? You need to practice stuff. You need to generate a way that makes it real for you. A way that makes it real for a lot of people is get a cric kit. Get a kit that has the supplies. Open it up. It's all good if it's not sterile. You're saving their life. It doesn't matter. The airway's not sterile anyway. Keep the cric kit with you. Get familiar with it. That makes it real. Because you say, hey, now I have this piece of equipment. If I don't know how to use it and I need to utilize it, that's a problem for me. Okay? Give them a chance. Cric them before they code. If they look like you're going to code, don't wait until they've been coding for 10 minutes and you can't get the airway before you try to do this. Okay? Do it early. All right. Journal Club 2.0, 2 lit reviews in the same lecture. I know everyone's super stoked about that. So this is Journal Club 2.0. First rule of Journal Club, read the article. I haven't given you the article, but I'm going to read them for you. If we're saying that the airway is a hard fork in the road in trauma, and we have to do something about it before we move on with this casualty, how good at it are we? When we look back and we say, okay, the airway is so important to us, so we must be like super good at it, right? Let's take a look and see if we are. Lit Review 2.0. All right. So the same dude, Mabry, this guy's freaking everywhere. Analysis of battlefield cric in Iraq and Afghanistan, Journal of Special Operations Medicine in 2012. This was not that many people. Retrospective. Okay, so we look back in time. When you look through the retrospective scope, be careful. There's bias there. The data is not always the highest quality, but sometimes you don't have time to do a prospective review, design a trial and go forward with it. Sometimes you only have retrospective data. They evaluated for success of pre-hospital cric. Success of pre-hospital cric meant that the cric was working when they got to the MTF. That's what it meant. So there's bias there because the cric could have been working and then who knows, something happened and it wasn't working anymore. But if it's not working when they get to the MTF, they didn't count it. So we're saying if the airway is unsecure, that is potentially a fatal problem. I already sort of buried the lead with the thing that came up, but 68%, that's terrible. That's a terrible cric success. All right. If we're saying the airway is a huge problem and it's potentially fatal if you don't have a secure airway, you just cannot tolerate 2/3 success. That's awful. Okay. 62% of the crics performed by medics at POI. It's all right. Just to like labor this again. So like 3 out of 10 people who got a cric made it to the hospital without their cric working. Do you think any of those people survived? They certainly all died. Most people with the cric actually died. But if your cric isn't working and you've moved on to other treatments, you're definitely going to die. Okay? So 62% of the crics were performed at point of injury by medics. Okay? This wasn't necessarily special operations medics, although that's the journal that it was in. The physician and physician assistant failure rate was lower, about half of the medic rate. So 15%, but still, like, that's, an 85% success rate. It's, like, not awesome. The medic failure rate was 33%. And that's not to say, okay, look, physicians are just better than you. That's not true, but the reality of it is, the data is what the data is. And if the medic failure rate is 1/3 of the crics we are performing are failing, then there's a problem either with the technique, the procedure, the securing of the airway, the transport of the patient. There is something in there that we need to improve on to give the casualty a chance. I mean, this is a real person. This is a husband, a wife, a daughter, whatever, a family friend, a mother. Like, this is a real casualty. The casualty is a real family and a real person back home. And so we need to give them a chance. 33% failure rate is just, it's totally unacceptable. It's totally unacceptable. All right, so that's bad. That is U.S. military, okay? With our huge budgets, our huge training, our fake helicopters that we do simulation in, our loads and loads and loads of equipment, all that kind of stuff. That's our failure rate. Let's look at other people. Israeli military, they're certainly getting a lot of cric practice now, most likely. This was in 2013, big journal of Trauma and Acute Care Surgery. We looked at papers from there before. Pre-hospital intubation success rates among Israeli Defense Forces providers. Okay, we'll go into this retrospective again. That should raise your bias. Red flags can be biased in retrospective reviews. Review of airway intervention and casualties for the IDF. This was like way more casualties than the previous paper. Let me see if I can see the previous paper. See how many total casualties it was. Oh, I didn't write it down. My bad. I suck. Okay, so this was 5,500 casualties. 400 or so had some advanced airway intervention attempted. Okay. The reason I chose this was because they did a lot of intubation, and so we're going to talk about that. Intubation was the initial airway management attempt with an overall success rate of 45% on the first pass, terrible, 36% on the second pass, worse, and 31% success rate on the third attempts. Those are all shockingly bad. And so why? Like, why were they so bad? The overall intubation success rate, when you put all the attempts together, was a 78% intubation success rate. That's awful. That's awful, awful, awful. That would never be tolerated in an American emergency department, OR, ICU, whatever. But like, why is it so bad? Oh my God, someone's at my door. I'm gonna ignore them. The reason it's so bad is just because they're in combat. Like, this isn't an ideal scenario. They're not in a clean ER. They're not in a clean, happy OR. They're in combat. And so that is why the intubation success rate is so bad, which is why we don't have it in our algorithm. All right, I'm going to pause this video and go to answer this friggin' door. Okay, so that intubation rate is terribly, terribly awful. That would never be accepted, like we said before. But they're in combat, so it's totally different, totally hostile environment, not the best way to practice medicine. 11% of these people, so 11% of these 400-ish people had a cric attempted. Their success rate is way different. I mean, this is, nearly 30% higher, 93% success rate. The end of this paper, they documented or they recommended sort of doctrinal changes to the Israeli Airway algorithm, saying that they should perform Cric after 1 or 2 intubation attempts. They did not recommend further intubation attempts. They did not recommend other airway interventions. They recommended going straight to Cric if you could not intubate. This is not really translatable to how we fight, but it is very enlightening because their success rate is just far higher. Now, who is doing these airway interventions? What is their level of training? Are they combat medics? Are they paramedics or EMTs? Are they physician assistants, nurse practitioners, physicians? That's all a little bit unclear from the paper. Also, America, thank God, fights its wars far away from home in the expeditionary environment. The Israelis semi-fight at home for the most part, and they live within close distance to trauma centers. Everywhere it's a helicopter flight away. They bring their medical capability far forward because they're not that far from their bases. And so it's a totally different way to fight than we do, but just the Cric success rate alone is very enlightening. Ours was 68. This one is 93. And also I think we should, lest we forget that oh, well, Cric is kind of scary. We should just intubate people. Look at these awful intubation rates. I mean, intubation success rate in America, first pass intubation success rates in the 90 percentages, and then overall intubation success rates in the very high 90s. And so the fact that this is 78% with a 45, 36, 31% first, second, and third attempt overall is so bad. So don't talk about intubation on the battlefield. It's probably a bad idea. This paper probably proves that. And we can get good at Cric. This paper also proves that. All right, last one. Okay, so we did the Americans, we did the Israelis. Now let's do civilian EMS. Okay, so this is pre-hospital and disaster medicine, a paper a journal I never heard of until I did this. This is a new paper, April 2024. Pre-hospital surgical cricothyrotomy, ground-based 911 EMS system. Which is funny because I don't think they use 911. They use a different phone number, but whatever. Retrospective review, 31 patients. So retrospective, hackles are up, bias. Only 31 people, so not that many people. But then again, not that many people get Cric, so it took them 10 years. They looked at 10 years of data to only get 31 people. So, that's not that much, but what can you do? You get the data set you get. Almost half trauma, slightly more medical, over half at an endotracheal intubation attempt prior to their cricothyrotomy. 94% is the Cric success rate. So I think we're proving with this paper the outlier in Cric success rate is us. The Israelis, British civilian EMS, American civilian EMS papers that I looked at had Cric success rates very similar to this one. So American military Cric success rate in the 60s is just bad. I mean, it's just way bad. And so we need to do something different. Does Sean Griffiths have the answer? No, I don't have the answer. But until we recognize hey, we're saying this is the modality we're choosing in TCCC, surgical cricothyrotomy. This is the data that shows how good we are at that, and it shows we're bad, so we need to change something. Okay, there's room for American military improvement in Cric success. Hint, hint, we're literally doing it right now. We are improving even if we're not practicing Cric physically. All right, we're at the end. The Airway, quote unquote, is a binary choice. Secure, unsecure, continuously changing, continuous reassessment, but it is a binary choice. It is a hard stop in the algorithm. TCCC and the Committee on Tactical Combat Casualty Trauma is simplified the Airway algorithm greatly over the last few years. Everything else is out other than recovery, position, head tilt chin lift, position of comfort, and surgical cricothyrotomy. That's basically it. Cross the mental Cric bridge now to get to a place where you can see yourself doing a cricothyrotomy. That will save the person the one day you maybe have to do it. There's massive room for improvement on Cric success in the American military. You're part of that movement now. You're doing it right now just listening to this. Okay? And then outside of TCCC, obviously the Airway algorithm is much more nuanced. We'll talk about that at a later date. Next up is going to be respiration. Hey, watch the videos. Recommend to your friends if you liked them. If you thought they suck, if you think I suck, if you think I'm annoying, email me, text me, call me, let me know what I can change. I want to make the engagement as high as possible for you guys. These take a long time to build, they take a long time to make, and so I want as many people to watch them. These are sent out to about 75 people every month when I send them out. We get an average of like 29 views, so that's sad for me. But watch them on the treadmill, listen to them on your way into work. They're probably better visual, but especially this one. But watch them when you're working out, watch them when you're doing dishes, watch them when you're whatever at home doing nothing, and try to get your friends to watch them and see if we can up our game and be the best we can. Thanks for joining me again. We're at our 20-minute mark. I'll get you guys out of here. Next up, respiration. See ya. Here's our sources. Nobody's going to read them, but there we go. Cool. Thanks, guys.